So I'm going to talk about a point of tension in breast pathology, which is a very common everyday problem that we all face if you look at any sort of breast specimen, and that is evaluating intraductal proliferations to determine whether they are benign or whether they are neoplastic. And this can be quite tricky at the low-grade end of the scale, as you know, because what constitutes cytological atypia at the low-grade end of the scale in the breast is really somewhat subtle. It's often not an overt atypia, although there are very useful cytological and architectural criteria that you can apply and will help you consistently to evaluate these. So what we're going to talk about during this lecture, first I'm going to start with a little bit on usual ductal hyperplasia, a familiar entity to us, but kind of break down some of the cytological and the architectural features that are most useful for recognizing usual ductal hyperplasia. And then we're going to contrast those with low-grade ductal carcinoma In-Situ, which is where a lot of the problems center in recognizing atypia of intraductal proliferations in the breast. I'm going to also talk about certain patterns of ductal carcinoma In-Situ that can be tricky for various reasons or that we are generally a little just more uncomfortable with. For example, micropapillary DCIS and distinguishing that from micropapillary usual ductal hyperplasia, taking a look at some of the confusing features of solid papillary ductal carcinoma In-Situ, a couple of other patterns that can be a little bit tricky from time to time in ductal carcinoma In-Situ. And I'll make a few comments about some problematic areas with intermediate grade and high grade DCIS, although these are often less of a diagnostic issue for us, especially high grade DCIS, because we can clearly see the high grade cytologic abnormalities. I will talk a little on the immunohistochemistry studies that can be helpful in the differential diagnosis between benign and malignant, mainly high molecular weight keratins and ER as adjunct studies. So to start with usual ductal hyperplasia, because this is often what we're trying to rule in or out when we're evaluating an intraductal proliferation. This proliferation here is a pretty standard usual ductal hyperplasia. And when we look at an intraductal proliferation, we can look at two sets of major features. One set is going to concern the nuclear and cytology, the cytology that's present, and the other set is going to concern the architecture. Depending on how you're taught, one or the other may be more prevalent to you or impress you more initially when you evaluate a specimen. I'm going to say that cytology is much more reliable than architecture. They're obviously both needed together for an overall assessment, but cytology will serve you well. Architecture will more often lead you astray. I'm going to start first by looking at the cytological features here of usual ductal hyperplasia. And this is a higher power view, and this shows very typical nuclei in usual ductal hyperplasia. And what you have is what I term a polymorphous population. It's not pleomorphic, it's not wild anaplasia cells, but the cells are variable. So the population shows some slight variability. It has a little bit of a jumbled and disordered look to it. There's just a little bit of randomness to it. The nuclei are predominantly oval. Some of them might be more round in their shape if you cut through the waist, but generally it's a oval nuclear population. And you can also see these nice nuclear grooves. There's one right there, and there are other grooves and folds in the nuclei. You also get these teardrop shaped nuclei with kind of a narrow end and a wider end, and that's very common in hyperplastic populations to have these kind of slight narrowing or teardrop shaped nuclei intermixed with the more oval nuclei. The chromatin is euchromatic, so it'll be very similar to that of the neighboring luminal cells in the unremarkable epithelium in terms of how darkly it's staining. And there's usually a light granularity to the chromatin, as we're seeing here with small nucleoli. So this polymorphous population, slightly variable nuclei that are oval to teardrop shaped with simple folds or grooves within the nuclear membrane, a lightly speckled chromatin, and small nucleoli are very characteristic of usual ductal hyperplasia. Additionally, in many cases, you may also see intranuclear pseudo-inclusions, these nice pink invaginations of the cytoplasm into the nucleus. And that's also a nice feature of usual ductal hyperplasia. You do not usually see that in a low-grade ductal carcinoma In-Situ. I won't say never, but it is fairly uncommon in low-grade DCIS. You don't see those nuclear pseudo-inclusions in every case of UDH, but if you have them, it's one more feature that you can add to the list that you're stacking up to decide whether these are atypical or non-atypical nuclei. So this just lists the features that we've discussed, very characteristic of usual ductal hyperplasia, and I find them consistent from case to case.